The information shared on this podcast is for educational and informational purposes only and is not intended as a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or qualified healthcare provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay seeking care because of something you heard on this podcast. The views and opinions expressed by guests or hosts are their own and do not necessarily reflect the official policy or position of any affiliated organizations. Reliance on any information provided by this podcast is solely at your own risk. Welcome back to the Healthy Image Podcast, where we break down healthcare, imaging, and prevention in a way that is easy to understand and empowering for patients. Today's episode takes you behind the scenes of ultrasound imaging, the exam that is often the very first step in answering important health questions. We are joined by our own two ultrasound technologists, Wendy and Leanna, who see it all from vascular disease and abdominal findings to thyroid nodules, pelvic imaging, and long-term surveillance. They're the ones capturing the images that guide diagnosis, treatment, and follow-up, and today they're sharing what they look for, how they scan, and why early detection truly matters. Let's get started. Welcome, Leanna. Welcome, Wendy.
Hi, thank you for having us.
Oh, we're so glad you guys
Thank you,
come
thank you.
on. Would you guys like to introduce yourselves to the guests?
Yes. Well, I'm Wendy. I have been with the company for 4 years now. I am the ultrasound department supervisor. I directly oversee 2 of our Pasadena locations and indirectly oversee the rest of our locations of the ultrasound department.
And I'm Leanna. I'm one of the first techs that Wendy hired. I've been with the company for about 2 years, and I specialize in OBGYN
Okay.
exams.
That's cool. So it's different to just be like an OBGYN ultrasound tech. Is that, like, do you scan babies or is it more just like...
So with OBGYN, it's pretty like a wide variety of it. So we get a lot of pelvics. We don't get too many second and third trimesters, but we do get a lot of first trimesters. So we definitely do those, but definitely gynecology for sure.
So how did you get into ultrasound as your career choice?
My career path actually took a complete 180. I started off majoring in political science, actually.
Really?
I went to UCR. I majored in political science, mostly because I just love the subject. I love politics. But after college, something in me just decided that I needed to be in the medical field. I don't know what it was. It's just something inside of me was just like, I need to be in the medical field. Once I did my research, I just fell in love with ultrasound. I really did. I think it has so much flexibility. Like there's so many just like lateral positions within ultrasound.
Yeah.
Even if you don't want to be a technologist and see any patients, you can be a specialist and maybe train doctors and technologists how to use the applications, to use our machines. You can travel across the country also and sell applications and be a consultant as well. So there's so many lateral positions you can take, and it can just take you everywhere.
Yeah.
So
Did you
I love that.
start at like X-ray or something, or you just went straight into ultrasound?
Straight into ultrasound? It's actually a special modality where you can cross-train. Yeah, so other modalities can cross-train, but ultrasound is just very specific.
Very specific. That makes sense. What about you?
So I actually used to be in the beauty industry. So for about 10 years or so, I was doing like makeup, lash extensions, like everything beauty related. And then there came a point in my life where I'm like, I need something with more stability. I need like, just more of a grown-up job, I guess. So I always knew that I wanted to be in the medical field. I just didn't know like what route I would take.
Yeah.
I started with phlebotomy. That just didn't work out for me. And then over time, I kind of came across imaging. And then I'm like, oh, like which one's the most exciting, diverse kind of, modality that I can get into? And then, ultrasound came across my path. And after research, I thought that was like the best choice for me.
Yeah.
Yeah,
I can tell. I mean, that makes sense. Your makeup looks fantastic.
Thank you so
Yes, it
much.
does.
Yeah. I'm like, don't look at mine.
That's great.
And what has it been like working at Huntington-Hill, and like what is the culture like there?
I think, well, I for one have worked so many places. When I first started my career, I started at private doctor offices. I worked at a urology clinic. I worked at private imaging centers, places like that. I've also traveled a lot for
Oh,
work.
really?
So I would say, honestly, to this day, nothing compares to Huntington.
Oh, that's good.
Nothing compares to Huntington.
That's nice to
I
hear.
think from the moment you walk in through our doors, And patients can tell you, once you walk in through those doors, our front desk staff is just top tier customer service. And once you get into the ultrasound department, especially, I think um, we just we're just very welcoming, and everybody's professional, and everybody knows what they're doing. You
Yeah.
know.
Yeah.
Um, as for the culture, I could speak for the ultrasound department. As a supervisor, I like to keep a culture where it's very open communication. All our techs have to communicate with each other, not only within ourselves, but with other modalities. So I know communication is very cliche and
But it's
very
cliche
corny.
for a reason.
It
Yeah.
is,
Yeah.
it is. And well, communication is the key to all relationships
Yep.
in your life, So, but I think Liana can give you like an
Yes.
impartial kind of view of the culture in the department. So,
So this was actually my first ever ultrasound job. Thanks to Wendy, I was one of her first hires about 2 years ago, and it was the best thing ever that like happened to me because just like starting off as a first job, it's scary, it's
Yeah.
intimidating. Like you don't know what to expect, you don't know like who you're gonna work with. Working with doctors, it could be pretty intimidating at times. But honestly, from like front staff to coworkers, supervisors, like higher ups, radiologists, everyone has been so like kind and patient and just helpful from like day one. And overall, it's just a very like warm environment. Everyone is just so friendly and like I love it.
Yeah.
It's a great
Well,
experience for
that's
sure.
good. That's
Yeah.
good to hear. I mean, I know I've only worked at Huntington-Hill when it comes to radiology, and so I don't have anything to compare it to. But when I do walk in the centers, I just realize I notice how everyone's so nice
Yeah.
yeah.
and patient,
Mhm.
and the patients are there most of the time for the first time, so they don't know what to
Yes.
expect or what's going on, and for the staff, they do it every day.
Yeah.
So, but it seems like they remember to explain to the patient and try to walk them through things, and they're just really friendly. But I'm
Yeah.
like, is it like that everywhere? Like, I don't know. I just know it's like that here, so that's good.
Yes.
Yeah, definitely not.
Yeah, yeah. You're like, I'm experienced. And I want to turn a little more towards the clinical side of things, but I want to talk vascular ultrasound. Um, what is a vascular ultrasound?
So vascular has a lot of different types of exams, right? So we can have anywhere from upper or lower extremity venous exam. We can have venous reflux exams. We can have renal duplexes, liver duplexes, mesenteric exams. So there is such a wide range of vascular exams, carotids, for example, too. But one of the main ones that we do get a lot are lower extremity venous to rule out any blood clots. So those are very detrimental for a patient's health because those findings are very, very critical. If we do find them, we would have to immediately report it to the radiologist because, they have to get in touch with their referring physician and see what their next plan of action would be, just so they can get the best treatment possible for the clots.
And would that just be literally just ultrasounding their legs?
Yeah, from the groin all the way to the ankle we look at to make sure there's no clots, and it's pretty much a bunch of like compressions, and then we check for velocity. We check for blood flow. We check for all that just to make sure the vessels are nice and open.
Okay.
Other vascular exams, I think, include arterial exams, which are pretty common where we work. So with arterial exams, we're not looking for blood clots per se, but we're looking more for buildup of plaque in the arteries of the legs. With that, those treatments are not as critical in most situations, but they do require a treatment plan. So if there's, let's say, moderate plaque to severe plaque, doctor might go in there and try to remove and clean out as much plaque as possible. If it's too severe, sometimes they add like a stent, which is like an artificial vessel that you bypass the occlusion that happens.
Just to open up that area.
Mm-hmm. You could also remove complete vessels as well and strip some of the
really?
veins. So with I know that Dr. Yagmai was a guest here earlier.
Yes.
I know you had a podcast with him, but we at Huntington-Hill Imaging, we actually have a dedicated vascular lab. So Dr. Yagmai is the one that leads that, and he is able to do an outpatient procedures for those venous studies, reflux studies, and arterial exams. So he's able to do those stripping of the veins, add adhesions to the veins to close them up, remove varicose veins, things like that.
Yeah.
So
I learned a lot when he was
Yes.
on.
Yeah.
Go back and listen if
Yes.
you haven't listened to that one. That was fascinating.
yes, he does a lot. He does
Yeah.
a lot.
And he explains it in a way that's easy to understand.
Definitely.
Mm-hmm.
Yeah. He described a tree trunk, and I was like,
Yeah.
oh, I'm a visual learner.
Yeah.
So
Yeah,
okay.
yeah, yeah. Mm-hmm.
And I know venous reflex studies can be long and detailed exams. What makes a reflex exam so important for patients with chronic leg pain or swelling?
So we do a regular DVT study with the reflux, and then after that, what we do is we make sure that the superficial veins are also patent. So it takes a little bit longer, of course, because you want to make sure everything is open and there's no clots anywhere. This is very important because what venous reflux means is that the valves in the veins are just not working properly. There's a backflow, and if that's the case, they're gonna need some sort of a treatment for that. If a patient is positive for venous reflux, they're going to have, aching in the legs, discoloration, a lot of pain, varicose veins. So it's definitely a good exam to get done if you're having any of those symptoms.
Right. Unfortunately, with the damaged valves or
Mhm.
weakening of the valves, when we have that, doctors usually don't treat the valves or they're not able to fix them. What they can treat is the symptoms that are affected by the
Oh,
reflux.
right.
So what we can treat is the edema and the swelling
Mhm.
by doing those procedures that we mentioned earlier. So like stripping of the veins and closing up veins using adhesives, things like that.
Right.
There's also methods where it's not surgical, so maybe like compression socks can
Mhm.
help, elevations of the feet and legs, also like a proper exercise as
Mhm.
well, and losing weight can also
I'm like,
impact it.
elevate feet or exercise? I'll elevate
Yeah,
my
yeah,
feet.
yeah. Just like-
Better option.
I'll put compression socks
Easier.
on too, might as
Yeah.
well.
There you go. There you go.
Okay, so switching gears here now to abdominal ultrasounds. What are the most common abdominal findings you see when you're doing an abdominal ultrasound?
With abdomens, I think for me the most common would be gallstones. A lot of the patients are asymptomatic, so they're not going to present with any pain or any symptoms. But once we're scanning the abdomen, we do get to
So
see
you're
those
scanning
big.
for something else, but then you see gallstones?
Those is not
Interesting.
something that they're here for, but
Right.
we're gonna find them.
Right.
Those are usually common. I actually had gallstones when I was
Really?
younger. It was hereditary. So all the women, female in my family, all had gallstones, and I was pretty young. I was 19 when I had my gallbladder removed. So
Oh my gosh.
very common,
Yeah.
more common than you think.
Yeah.
Yeah. So.
So you see it on a lot of patients and they have no idea.
They have no idea, but they come in. Sometimes they come in with symptoms, and right away we can tell. It's like,
Yeah.
oh, easy,
Yeah.
it's fine.
What would symptoms be of gallstones?
That'll be mostly right upper quadrant pain. So in your abdomen, if it hurts in the right upper quadrant, pain after a meal, always pain after a meal, and maybe like epigastric pain, which is like middle of your kind of abdomen,
Uh-huh.
upper abdomen, and then radiating towards the back most of
Interesting.
the time.
Let me take notes.
Yeah. Tricky.
So when it comes to gallbladder exams, specifically, what do patients usually report and what do you look for first?
So the more typical or severe pains or symptoms that a patient might have is going to be like fever, chills, even elevated white blood cells. Another testing that we do is something called the positive Murphy sign. So what we do is we get the ultrasound probe and we just kind of push hard like onto the right upper quadrant to see how the patient reacts. A positive Murphy sign would be if they like flinch and kind of jump with like aching pain. That's like a good indicator of, okay, this is serious. Like there's probably infection, and we would call the radiologist to see, do they go to the ER? Do we
Mhm.
call their doctor? Like, what would we do next? But those are the more like concerning and more severe symptoms
Yeah.
of the gallstones.
So now renal cysts. How do you document them and what imaging features help identify a simple cyst versus a complex one?
Well, under ultrasound, solid components and fluid components are very easily detected. So, fluid components, which are cysts, right? They're like fluid-filled sacs, right?
Okay.
That's what cysts
Uh-huh.
are. Um, if they're completely anechoic, meaning void of color completely, they're going to be pitch black. That just means that it's fluid, right? If there's any brightness to it, any at all, we call it echogenic. So any brightness at all in the cyst, that means it's more complex. That there's some solid components to it. That would usually trigger some suspicions to it and would require a follow up.
So if you wouldn't see anything then if it's just black, or would you still see like the outline of it or like
Yes. So we'll see the sac itself,
oh.
but inside the sac, it's just going to be a perfectly like a circle,
Mhm.
very but completely void of color. So it's just going to be black.
Interesting.
Yeah, so even our vessels are gonna look black usually. If we don't put any color on them, they're just gonna look pitch black.
I heard ascites is something you guys also look for? What is that?
So ascites is pretty much free fluid in the abdomen. It could be in the pelvis. Oftentimes, patients with cirrhosis will have ascites. Of course, anytime we do see it, we have to document it, be precise on the location, to see how much there is, to let the radiologist know if it is a severe amount, and then after that, they would just relate to their primary physician to see what next steps they would want to take if it's like a lot
And
of
do you
ascites.
approach scanning a different way in that scenario, or would it be the same?
Honestly, we pretty much documented like any other thing that we find. So location is always a must, just so they know where to look for if they are to do a procedure. We like to put color over it just in case we want to see if it's simple or complex fluid. That also matters. And then we like to do it in different areas, different planes. Take images, take videos, just to really show like where the ascites is and how it looks.
And after that, it depends on the referring physician of whether they want to drain the fluid or not. So if they want to drain the fluid, it's always going to be in a hospital setting, very sterile procedure, right? And what they do is under ultrasound guidance, they drain the fluid using a needle. It's called paracentesis
Oh, okay. And that's done at the hospital.
at the hospital, yeah.
So switching gears again to now thyroid and soft tissue. What can an ultrasound of the thyroid or soft tissue detect?
Well, thyroid ultrasounds are one of the most common exams that we do at Huntington. We do quite a bit of them, okay?
Mhm.
So, with that being said, we're looking at, abnormal lymph nodes, we're looking at abnormal growths, nodules, which is just growths in the thyroid. From there, when we image it, the doctors decide, they use a certain criteria where they decide which nodules are benign or suspicious looking. After the imaging, the doctors, they use like a certain criteria where they measure the nodules to see if they look benign or they look suspicious. If they do look suspicious, they typically have them come back every year for follow-ups, or if they look very suspicious, then they could schedule a biopsy right away.
Mm.
Mhm.
And then with these biopsies, one of the major criterias that meets the biopsy criteria would be like irregular borders, if it's a taller rather than wide. Like those are more characteristics that the radiologist looks for to see, of course, among other things,
Mhm.
to see if that nodule would be eligible for biopsy. But that's whenever they would come, the radiologist takes a look at it, then they'll go in for the procedure. They'll numb them, everything. And then once they're all set up, they go in with a 25 gauge needle. They'll do like 3 passes per nodule to make sure they get adequate samples. And then what they do is they send that over to cytology. So once they send it to cytology, that's whenever the results come back benign or malignant. The whole process of the biopsy is like max like 1 hour. Just kind of depends on how difficult it is and how many nodules we're biopsying.
Right. And the cytology results take about 1 to 2 weeks turnaround.
Oh, wow.
And we perform all this at Huntington. So come
One
join us.
stop shop.
Yes.
So now I want to go on to pelvic ultrasounds. Why might a patient need a pelvic ultrasound, and would it be different for males versus females?
So males would typically get a pelvic ultrasound. Let's say if they're having any bladder complications, any prostate complications. One of the major things would be for the bladder. The major thing with the bladder would be like if there's some sort of a blockage somewhere where the ureters are not working properly. It causes like a backflow in the kidneys. Causes something called a hydronephrosis. So if patients have that, it could be pretty severe, which causes the inability to void properly. If patients present with a lot of pain, and then again, we notice they can't void, there's a lot of fluid in the kidneys, we call the radiologist and then see what their next plan would be per the referring physician as well.
With the female pelvic exams, those are going to be the also most common, more common than the male exams. And they're also the most invasive exams that we perform at Huntington. So with the female pelvics, we're taking a close look at the uterus, the ovaries, the cervix, the endometrial lining, um, also looking at the bladder as well. With that, it's usually because females come in usually presenting with symptoms like bloating, heavy menstrual cycles, irregular cycles, pain, pelvic pain, pelvic pressure, things like that. And these are usually or most commonly caused by fibroids, by endometriosis, by PCOS, and these can be detected with ultrasound. And it's also a good note to just remember that with fibroids, it's extremely common among female patients. It's extremely common with our female population because I believe it affects 80% of females
Really?
by the time they're 50.
Oh my
So
gosh.
it's extremely common.
Yeah.
And those symptoms include the heavy menses, the painful, debilitating periods, pelvic pressure, and also urinary frequency, which I think is very overlooked. But remember, fibroids are growths in the uterine, just walls, the uterine walls. So if they get large, they're pushing against other organs.
Oh,
Yeah.
yeah.
So
that
they're
makes
pushing
sense.
against your bladder, which makes you have to go to the restroom
Yeah.
more often.
It could kind of mimic a pregnancy in a way,
Yeah,
you know,
if
if
they
they're
if
large
they get
enough.
large enough, yeah. And also a lot of people opt out of surgery, but you have to remember with when you carry such a large mass in your uterine, your uterus, it's gonna cause just some heaviness on other organs, you know?
Yeah.
It's gonna push against the ovaries.
Right.
It's gonna push against the bladder.
Are there other options besides surgery to resolve fibroids?
There's a way that you could also cut out the circulation, like the blood supply to the fibroids, using like ablations and laser techniques, things like that. You could also do that.
Yeah.
It's also hormonal. Like these conditions are also very hormonal induced. So patients after menopause, it's when the fibroids start shrinking on just themselves.
Really?
Yeah. So after a certain age, doctors don't typically like to perform any surgeries on a
Right.
female patient, and mostly because after when you're in menopause, you're not producing as many hormones, so they'll just shrink on their own.
So they can grow because of hormones.
Yeah.
Like patients who are on birth control, for example, I feel like they're more prone to either grow fibroids, or if they already have it, it can cause them to increase in size because, you know, those are hormones, you know, entering your body.
Right.
So that's going to definitely stimulate the growth of a fibroid as well.
Right. That makes sense. Doesn't sound fun though.
No.
No.
But very common.
Yeah.
Yeah.
That's crazy. 80%.
80% by the time you hit 50. Yes.
I think eight out of 10 patients, if I were to do a pelvic in one day, they would have
Fibroids.
fibroids. Even if it's a
Fibroids.
small one, at least 8 out of 10 would have it for sure.
So can you have fibroids and not like feel anything? You just don't know
Absolutely,
you
absolutely.
have them?
But it is, I believe, one of the leading causes of infertility.
Really?
So if you have, let's say you're young in your childbearing years and you want to have a child, some of the fibroids can prevent the fetus from growing and developing. So that causes a miscarriage. So it's
so complex.
yes, the female body's
I
very
know.
Yes.
We're complicated in every aspect that you can possibly think of. Literally.
Yeah.
And I know ovarian cysts are also something you guys scan. Tell me a little bit more about those.
Ovarian cysts are very common, very, very common. So they could be anywhere from simple to complex. So depending on, you know, the characteristics of it, there's going to be certain follow-ups. So let's say if there's a 2.5 centimeter, you know, simple cyst, that's really not going to require much follow-up. It's most likely going to resolve on its own. However, there are some cases where cysts are a little bit more complex. So they're going to be larger. Let's say, for example, up to 5, 6 centimeters. They're going to have septations. They can have debris inside. It could be more of like a hemorrhagic cyst, which these are a little bit more complex. And it gets even more complex after that. So depending on the severity of it, radiologists are going to recommend up to 6 weeks follow-up, 8 weeks follow-up, just kind of depending on the size and the appearance of the cyst.
Yeah.
Right. I also think it's very important to note that there's a big difference between an ovulating cyst and a regular ovarian cyst. So with an ovulating cyst, it's very normal. Everybody with a normal menstrual cycle is going to experience this every month, right? So our ovaries produce a cyst that can be up to maybe 3 centimeters as big. So once it produces this cyst, it'll rupture and then it'll release the egg,
Oh,
right?
right,
So it'll
right,
release the egg. So when it's rupturing, when it's about to ovulate, under ultrasound, the doctor might not differentiate between a complex cyst and an ovulating cyst. It might be too complicated for him to really diagnose. So that's why, like Liana mentioned, the 6-week follow-up and 8-week follow-up is just to make sure that it's resolved.
Right.
So they're very, obviously we go through this every month. So depending the time that you come in,
Yeah.
don't be alarmed that the doctor's, you have to come back in 8 weeks because we saw a cyst.
Yeah.
It might just be an ovulating cyst.
Right.
So
Yeah.
important distinction.
Yeah. That's good to know too.
Yeah.
So I know how you mentioned earlier how, these pelvic ultrasounds can be pretty invasive for women. I've had one before, and my mind was just, I was like embarrassed,
Yeah.
and I'm sure you guys do it all the time, so
Yeah.
you don't care. But how do you make the patient feel comfortable when they're having one of these exams done?
Honestly, we do these so often, and the biggest thing is, like you said, make your patient feel as comfortable as like possible. So I like to, greet them, always talk to them like with a very warm tone. You just want to be kind always. And then as soon as they come into the room, we ask the questions. I love to explain the procedure. I don't care if you've done it before. I don't care if you had one done last month. I always will go over the procedure with you. Just kind of letting you know like what the process is going to be like, what to expect, if you're going to feel pressure. I like to also communicate throughout the exam. Like I'll ask them, like if they're doing okay. I let them know if they feel too much pressure. If they do, let me know. I can always modify. And then our biggest thing is if they're experiencing pain, which they really shouldn't, but if they do, I always let them know, like tell me, I can stop the exam.
Mm-hmm.
So it's super super important to let them know, like they can end it at any time. It just provides more comfort, I feel like, for them, like they feel heard and seen.
Yeah.
Exactly. So whatever everything that Liana said, this is what I teach all of my new techs, all of the new hires. And as I mentioned earlier, Huntington, we adhere to a very strict patient-driven policy.
Mm-hmm.
So we have to make them as comfortable as possible. And I do want to reiterate what she said that if you're having a pelvic ultrasound and for whatever reason you decide that it's not for you anymore, or you feel uncomfortable, we could stop the exam mid-exam, 2 minutes in, 10 seconds in. So we
Mm-hmm.
can completely stop the exam whenever they want.
Yeah, it's at patient discretion.
Yes.
Yeah.
Yeah, that's
Mhm.
good. Do males get any invasive exams?
The most invasive exam that we do for male patients is going to be a testicular ultrasound. The most
Thyroid.
critical findings that we typically see, or especially looking for, are going to be testicular torsion or epididymitis. Both very severe. They both cause severe pain. They're critical findings. Testicular torsion is pretty much where the spermatic cord twists and then it cuts off blood flow to and from the testicles. So that's, of course, why it's going to cause a lot of pain. In some cases, depending on how severe it is, patients can have permanent damage, which can result in surgically removing them if it's, if it.
Necessary.
It's
So when you do have incidental findings, how do you document them clearly without alarming the patient?
easy.
Honestly, any incidental finding, no matter where you're at in the body, you treat it like anything else. So you don't make anything obvious, you don't make any faces, you just take your images, you take your videos, color images, whatever it is, document it as incidental findings, and then after that, they're most likely going to order another separate exam to really focus on their findings. But the main thing is just go about like your regular exam, don't make it like obvious.
Mm-hmm.
They're
Yes.
they're not going to know what you're doing or how long it's supposed to take. So just take your images. As long as you're not ignoring it, that's what matters.
Right.
hmm And with documentation, it doesn't have to be completely thorough because it's an incidental. So
Mm-hmm.
as long as you mention it, document it, and just image it properly, the doctor will write it on the report. And they
Right.
have to come back with the proper order in order to have a dedicated exam for that.
Mm-hmm.
hmm
To look further and
Yes.
yeah. Have you noticed patterns in which incidental findings show up most often during routine scans?
I think with my experience, I don't know about you, but for me, I think when we're scanning carotid ultrasounds, we see thyroid nodules.
Mm.
So carotid are the vessels in the neck, right? They
Right.
supply the blood to your face, your head, your brain, everything, right? So we look at carotids every day and we are in that same area. So there is no missing the thyroid. We're always going to take a look at it no matter what. So if we see nodules, we're going to document them.
Mm-hmm.
And then remember, nodules are also common. They affect about, I believe, 50% of the population by the
Really?
time they're 60. Obviously, not all of them are going to be suspicious, but they are very common, so that they need to be taken a closer look at.
Another common incidental finding is if we're doing, for example, a right upper quadrant scan, if we're looking at the liver or if we're looking at the kidney, the right kidney, because they're both like on the same side. So let's say, for example, looking at the right kidney, as I'm doing my sweeps, doing my exam, I notice a lesion in the liver. Most likely it's going to be a cyst if it's incidental because they're more common, or
Mm-hmm.
hemangiomas. Again, we don't ignore it, but that's one of the more common incidental findings I would say that we see, like
Right.
if you're in the abdomen.
Mm-hmm. Now, for the more chronic conditions, for patients that you see, how often might a patient need a follow up ultrasound for a chronic condition?
So, typically for, let's say, liver cirrhosis, patients will come like once a year for follow-up. Chronic kidney disease, they'll come once a year. These are good annual follow-ups to just kind of get a good idea of where the organs are at, if there's any changes, if, looking for ascites, any other abnormalities, growths that shouldn't be there. But it's good to get these in annually just to make sure
Yes.
it's like,
And that's across the board. So most like for fibroids, for nodules, for
Mhm.
anything like that, they're gonna come in once a year usually.
And why do you think that ultrasound is preferred for long-term surveillance imaging?
Well, with our follow-ups, if we're doing surveillance, if they're coming in every 6 months, let's say, or even a year, other modalities are using iodine solutions. They're using radiations. It's also very expensive.
Mhm.
The machinery is a lot more expensive. So I think with that being said, ultrasound is the least invasive and also the most affordable.
Mhm.
So we are going to monitor the growths, the appearance, anything like that with
Mhm.
every follow-up with
How
ultrasound.
long does a typical ultrasound exam last? Is it minutes?
No,
Like,
it depends. Some could be anywhere as quick as like 10 minutes. Some could last like an hour and a half, like the refluxes.
mm.
But I feel like a good average is about 30 minutes,
Oh, okay.
like
yeah.
give or
So it's a
take.
fairly quick exam
Mm-hmm.
too to
Yeah,
have
Yes,
the patient come in.
exactly.
And,
Yeah.
yeah.
exactly.
Every half an hour we have a patient scheduled.
Yeah.
Hmm.
The only other time where like a radiologist will want another type of imaging modality done is, let's say, if we do a certain exam and they don't get the necessary readings from that ultrasound, that's whenever they'll do something a little bit more extensive, like a CT or an MRI, to get a better
Mhm.
visualization of it. But typically, ultrasound would be the first choice for it.
Right.
And then if they want any extra, that's when they would start ordering
Yes.
something else,
Yeah.
just in case.
Yes.
I noticed a lot of insurance companies too will want to see the ultrasound results before they'll even approve
Mm-hmm.
the MRI or the
Right.
CT.
Right. So,
So it's like one of the first
Yeah.
steps.
right.
Yeah.
Right. Right.
Have either of you experienced
Sorry.
seeing the same patient multiple times and kind of seeing how the imaging has helped manage their care?
Yeah, absolutely. Absolutely. If we've been there for a couple of years for
Mm-hmm.
you,
Yeah.
Hmm.
we do get to see a lot of follow-ups.
Yeah.
I had a patient recently that they were here a year ago and they had very fatty liver, which is just you could see it with enlargement of the liver, a very bright liver. That means that they have just a lot of fat tissues surrounding the liver.
Hmm.
They were here a year ago, and then I saw them recently, and it was a complete transformation. So
Really?
that liver looked completely
Hmm.
healthy. You couldn't even tell it's the same
Yeah.
patient, and the patient themselves, they just looked
Hmm.
healthier,
Yeah.
and they looked very much more upbeat.
Right.
And you can see the just the changes in their demeanor a lot in the
Hmm.
patients.
Yeah.
Hmm.
And you gave them the results that led them to this healthier transformation.
Yeah.
Exactly,
That has to be
exactly,
rewarding.
right. And just a note that a fatty liver is common as well, just your eating
Hmm.
habits and your dietary, like, plans, but it's also reversible. And
Mm-hmm.
it's,
Oh.
just with the lifestyle change.
Hmm.
So I'm sure the doctor spoke to that patient, and once they made those changes, it was a complete
Yeah.
transformation.
Do you guys do ultrasounds for cancer patients too?
Oh,
We do.
absolutely.
Yeah.
Yeah.
I actually had there's actually a lot that we saw. So one of my first, like the first year I actually started working here, I had a case. I think I had you come with me for that one because it was pretty complex. It was I'm pretty sure it was like an ovarian lesion going on. She had abscesses from like her pelvic area that were pretty much extending into her flank area. So she had no symptoms, she had no pain, but as soon as I put the probe down, it was just very complex. Like there were septations everywhere, fluid. It was kind of hard to like distinguish what's what.
Oh wow.
And then we pretty much read the report, and then it was corresponding to more like malignant findings.
Hmm.
So that's whenever it's like really as sad as it is, but it is also rewarding that we make a difference in someone's life because we found that we were able to show the radiologist these findings. They were able to make certain calls to help the patient and give them the necessary treatment. So that's when I can say it's very rewarding,
Yeah.
the
Yeah.
things that we can do for our patients.
Yeah. And it's so rewarding just knowing that the patient is getting a proper
Mm-hmm.
diagnosis and proper care.
Hmm.
So a lot of the times we also see patients being treated for one thing, and then we have the ultrasounds and notice that, you know, the symptoms are coming from something else,
Right.
right? So I mean, we've had patients where they're coming here because they think they have gallstones and they have that typical symptoms, but we check and it's cancer, it's gallbladder cancer instead. So they're being treated for digestion issues, but it turns out to be,
Something
something
different.
different. So
Yeah.
it's nice to be able to follow up with those.
What's one thing you wish patients understood about the role ultrasound technologists play in their care?
I really wish that they understood that we're not the doctors. As much as we do help them and we know a good amount of the information, we're not there to diagnose. We're the eyes for the radiologist. So we take our images as needed. We take our videos. But at the end of the day, we don't make any calls. That's going to be up to the radiologist and their referring physician. But oftentimes we get asked by patients, "Oh, what did you see? What did you? Can you tell me anything?" As much as we do know a lot of the times like what it could possibly be, we're not allowed to say because there can be times where a radiologist might disagree with you, or they think it's something else, or we think it might be more severe than what it actually is because we're we're helping them like describe what it is,
Right.
even though we see it pretty often, we can't know 110% sure like that's what it is.
Right.
Yeah.
So I wish that they understood that we can't really tell
Yeah.
them,
Like you can see that something's abnormal,
right.
but the radiologist has to be the one to diagnose it.
Exactly.
Yeah.
Because let's say I misdiagnose them and I say the wrong thing, and then on the report it's something completely different. That's a liability. Like we
Right.
could lose our license, we could lose our jobs. The patient could be like really upset. It's very, very important to make sure like we don't tell them certain things.
Yeah. You don't want to give the patient the wrong diagnosis.
Exactly.
Yeah. Just on a lighter note, what is a moment from scanning that made you laugh, smile, or remember why you love your job?
A life-changing experience that I actually had with the patient not too long ago, a few months ago. This patient was paralyzed from the waist down, like, but he was very independent, like, did everything on his own. And then it was just for like a simple exam, but he came for annual follow-up. So we start talking, and then he's just trying to like get me to look at life with a different perspective, somebody like this who is immobile but so independent. He was sharing some stories with me that was just like very, very humbling. And don't take everything for granted. Like, you need to appreciate life for the little things. And this guy who lost a lot, like that's a big deal, and he's still so positive and so happy. And the things he was saying to me, it was a huge eye-opener.
Yeah.
Very life-changing
Yeah.
for me.
Right. For me, as corny as it may sound, I love my job. I do. Every day it's just a good day. I have a great group of team, and support. So I really love it. But one funny issue, I think, one of the most memorable kind of times I remember that I had a patient. I guess I was in a zone and I was taking patient after patient. And then my next patient was a thyroid exam where we're checking the neck, and I asked him to pull down his pants. So that was very awkward for
Wrong
both
body
of us.
part, but you
So that
were
was
just
very-
in the moment.
I was in the moment, and he was about to. I was like, "Oh, wait."
See, you made him feel comfortable enough that he was about
Yeah.
to.
He's like, "You're the expert."
He's like, I don't know where my thyroid is. I don't know.
So,
That's
it's a fun
funny.
job. It's a fun job.
Yeah. Well, thank you guys so much for joining me and explaining ultrasound in a more in-depth way. And
Thank you for having us.
Yeah.
Yeah.
Thank you so much.
I
And
learned a lot. I'm like taking notes. And
Glad we could help.
Yes. Look out for those symptoms, y'all.
yeah, seriously. Well, thank you to Wendy and Leanna, our ultrasound technologists, for sharing what it's really like to be on the front lines of detection. From first findings to long-term follow-up, their work plays a powerful role in guiding care, answering questions, and
There you
helping
go.
patients take the next step with confidence. If this episode was helpful, share it with someone who might need it. And as always, stay curious, stay engaged, and stay healthy. Bye.